Okay, now colitis associated cancer. Now we know that cancer is associated with both Crohn's disease and with ulcerative colitis. Okay, in Crohn's disease, we can see the malignancy of both small intestine and colon. Rectum is generally not involved in Crohn's disease. In ulcerative colitis, in majority of the cases, there is tumor of the colon, or in almost all the cases, there is tumor of the colon and rectum. Okay, generally we see the tumors more on the left side or near the rectosigmoid region. Now, what is the difference between a tumor which is associated with colitis and with in a conventional CA colon or CA rectum which we are reading routinely? Okay, so I will make a table to make you understand. Now this is a colitis associated cancer, and here there is a sporadic cancer. Okay. So in colitis associated cancer, it arises from flat dysplasias or DALM, which is a dysplasia associated lesion or mass. Okay, whereas sporadic colonic cancer, they arise from adenomatous polyps. This we know that sporadic cancer arises from adenomatous polyp. Here it arises from flat dysplasias or DALM. Now, there are multiple synchronous lesions or multiple synchronous colonic cancers, which is seen up to 12%. Okay, in colitis associated, whereas in sporadic it is 3 to 5%. Here the mean age is 30 years, here it is 60 years. It is distributed throughout colon and the distribution is uniform. Here it is more left-sided. Okay, and it is mucinous or anaplastic variant, which is more common. Here the mucinous or anaplastic variant is less common. Okay, so this is important differences between sporadic and colitis associated cancers. In sporadic, which we all know, it is mainly adenomatous, mainly left-sided, seen generally at the age of 60 years or more. Sporadic lesions are seen in only 3 to 5% cases, and mucinous lesions are less common. Okay, whereas in colitis associated cancer, it arises from flat dysplasia or DALM. There are multiple synchronous lesions seen up to 12%. Mean age is 30 years to 40 years, distributed throughout colon uniformly, and mucinous or anaplastic variants are more common. But the prognosis is similar in both colitis associated cancer and sporadic cancer. Okay, so this question is very commonly asked, that as it is associated with mucinous variant more, so it is associated with poor prognosis. No, the prognosis is similar between both the two groups. Okay, now a few more important points. Now this colonic cancer is similar between Crohn's colitis and ulcerative colitis. Okay, so the rate of colonic cancer is similar or almost similar between the Crohn's colitis and ulcerative colitis, whereas small intestine malignancy is more in Crohn's disease. Okay, so Crohn's disease is more than ulcerative colitis. And what is the most common site? Ileum. Okay, cholangiocarcinoma is seen more in ulcerative colitis. Why? Because primary sclerosing cholangitis is more in ulcerative colitis. Okay. Now, what are the risk factors for malignancy in ulcerative colitis? Risk factors for cancer in ulcerative colitis. Two points I've already told you. If the extent of the disease is more, for example, if it is pan colitis, then it is a high risk factor as compared to a left-sided colitis. And second thing is, if the duration of the disease is prolonged, then there is a more risk of developing malignancy in ulcerative colitis. The inflammation or the mild variety or the severe variety, whether it is associated with more chances of malignancy or not, is not proven yet. So the two most important risk factors are the duration of the disease and the extent of the disease. Okay. The first thing is duration of colitis, which is very important. Second thing is extent of involvement. Okay. So for example, pan colitis is more risky than left-sided colitis, which is more riskier than a proctitis. Okay. These two are the most important risk factors. Others are presence of PSC or the primary sclerosing cholangitis or a family history of colorectal cancer. Okay. And another thing is pan colitis with disease diagnosed at young age, then there is a very high likelihood of developing malignancy later on. Okay. Now, this ulcerative colitis related colorectal cancer, I have already told you, it is equally distributed. The chances of synchronous lesion is up to 12%, and it is more mucinous type, but the prognosis is similar to sporadic cancer. Okay. Now, I will write the features. It is multicentric, in 12%, evenly distributed, throughout the colon. It is more mucinous, more anaplastic or poorly differentiated, more infiltrative, and highly aggressive. But prognosis is similar to sporadic colorectal cancer. Okay. This is important. Multiple times they have asked question on this point. Prognosis is similar. Now, as the duration of ulcerative colitis increases, the chances of developing malignancy also increases. We have to remember the percentages. Okay. Now, risk of malignancy increases with duration. Okay. Now, what is the risk? This is in ulcerative colitis. What is the risk? The risk is 25% at 25 years, 35% at 30 years, 45% at 35 years, and 65% at 40 years. Okay. The risk is 25% at 25 years, 35 at 30 years, 45 at 35 years, and 65 at 40 years. So you can see the risk is increasing more as the duration increases. So this is to remember. Now, in Crohn's disease also, the risk increases in Crohn's pancreatitis. Risk increases in Crohn's colitis also with duration. And what are the percentages? 2% after 10 years, 8% after 20 years, 18% after 30 years. If you see here that it is 18% after 30 years, whereas it is 35% at 30 years in ulcerative colitis. Okay, but statistically there is not a significant difference. So overall, if you will see from MCQ point of view, the chances of development of colorectal cancer in ulcerative colitis and a Crohn's colitis is similar. Okay, so that is for MCQ point of view, but this points also you should try to remember. Okay, now most common cause of death in Crohn's disease is development of a GI malignancy. This is important. Other causes of death can be sepsis, thromboembolism, or electrolyte imbalances. But the most common is GI malignancy. Now there is a patient